Melissa says, I had an MI, myocardial infarction, heart attack, in July. I currently take lisinopril for blood pressure control. My cardiologist wants to add a beta blocker. He said beta blockers are good after MI. Your thoughts? For the latest in health-related information and ways to save your life, check out the newsletter.
I would say that's the standard, and I will confess a few months ago I thought the same, because beta blockers can reduce the amount of effort that the heart makes after a heart attack and reduce the blood flow that is required for the heart to function, but they have a really bad side effect that is induced insulin resistance. So in the long term, I don't think those are the best option.
You bring up a great point. So many people come to us and they're on beta blockers. I had 2 come to me yesterday on beta blockers, no stents, no MIs, no heart failure, just for blood pressure. And that's old medicine. That's not good medicine. And as Jesus said, the reason it's been found to be not good medicine is that beta blockers, like high dose statins, push you down that diabetes highway. There are some that have been made, like carvedilol, which are supposed to be better, but the bottom line is just avoid them if you can. Now, as Jesus also mentioned, it's not that simple. People that have had instrumentation to their heart, like a stent or bypass graft, people that have had a recent MI, that have heart failure, all of these things tend to put the patient at greater risk for dysrhythmias. And these things tend to decrease the probability of dysrhythmia. So after a stent, after bypass graft, yes, it makes sense. The data is pretty clear about that. And for people with many versions of heart failure, yes, the data is pretty clear about that. But again, your doctor needs to be aware of what they're doing and able to balance those competing issues. You know, the fact that so many people come in and they're just on it for regular blood pressure is clear. It's the same thing that we see over and over and over again. The vast majority of primary care doctors do not know how to diagnose and deal with the major cause of heart attack and stroke, and that is insulin resistance.
And that's what's on the guidelines. In Mexico, we have some guidelines that physicians are tending to use because those are government-based. So the government tells you, hey, this is the way you should treat each disease, you know? It's basically supposed to be based on evidence. And I got this tattooed on my forehead while I was studying that. First option for hypertension, diuretics. Then you use ACE inhibitors. And I think fourth option was beta blockers. So that's what the guidelines say.
So what you're saying is there's another guideline you don't believe in?
Not all of it. There's some good spots over there that can be useful, but not all of it.
That's the thing. I agree. I mean, a whole lot of guidelines are really good. For example, the American College of Endocrinologists, the American Association of Clinical Endocrinologists have both said, don't use hemoglobin A1C to diagnose diabetes because there's hemoglobin involved, and anything that impacts hemoglobin can impact that study. But 99.99% of doctors out there ignore that and use hemoglobin A1C. That's one area where I'd say use the guidelines, they're correct. But then there are other places, as you've pointed out. Another place where I don't agree with the guidelines is the ADA, American Diabetes Association, and AHA, American Heart Association. Guidelines committees say don't use CIMT. I understand why they say that. There's a garbage in, garbage out thing regarding arterial age. But there's no garbage in, garbage out regarding the most important piece, and that is whether the plaque is soft or stable. And that's very, very repeatable. That's very easily done. And they've thrown the baby out with the bathwater. Why would I need a beta blocker after an MI? That's what we just talked about. So again, I think you put that information in before we talked about it. I hope that we got the coverage that you needed on that question. Bottom line is any kind of instrumentation like a stent, bypass, or a heart attack all increase the risk for issues, especially dysrhythmias, and that's needed for